I am Dr. Robin Chatkan, gastroenterologist, and this is part of my every Tuesday at noon live office hours series. And my only regret is that I can't be with you all actually in person and see your faces, but we've been spending a lot of time talking about constipation, and I want to tell you, constipation is one of the commonest problems that I treat in my gastroenterology practice. And I like to remind people, constipation does not fall out of the sky into your lap. So this idea of idiopathic constipation, that there's constipation for which there's no cause, is a little bit of a myth. Now, there are causes that we can't necessarily fix. There are some structural, anatomical things that are challenging, but those are still causes that need to be identified. So just like irritable bowel syndrome, where I'm always sort of saying, roll up your sleeves and figure out what is making your gut irritable, I want you to take the same approach. I want you to reject the idea that you're just constipated because, that's how it is. And remember that the default setting for the gut is that things are supposed to move from north to south in the gut and out the butt, as my daughter used to like to say when she was little. They're supposed to move in a timely fashion. That is our default setting. So when that isn't happening, it's because something's wrong. And rather than just apply a pharmaceutical Band-Aid, which I'm not fond of doing, I want you to be medical detective and to figure out your constipation. So to talk about solutions, we have to backtrack a little bit and talk about what's causing constipation in the first place. I'm not going to spend a lot of time on this, but what I want to say is that I approach it when I see a new patient in the office who has constipation. There are really three buckets. There are three things that I'm thinking of. The first is diet and lifestyle. The second is medicine cabinet. And the third is a combination of sort of anatomical, physiological, and hormonal. Okay, so again, I'm going to recap. There are three buckets that I like to think about when I'm approaching a new patient with constipation. The first is diet and lifestyle. The second is what's going on in the medicine cabinet. And the third is a combination of anatomy, physiology, and hormones. Okay, so we'll take the first bucket, diet and lifestyle. In terms of diet, I want to know how much fiber, what type of fiber, hopefully not a lot of processed fiber. So how much fiber are they getting in? How much water are they drinking, right? Those are the two most important things for diet. And then for lifestyle, are they moving? Here's a thing that some of you may not realize. Your digestive tract is a long muscular structure. It is a kind of muscle not that different from biceps. I've been trying to show off my guns, but I have a sweater on. Not an itchy sweater this week, thank goodness. So it is a muscle, right? And what happens when you are not working your muscles? They get flabby and weak. And the same thing happens to the digestive tract. So you can't sit around not moving, not exercising, and think that you're going to have a strong muscular digestive tract that's going to briskly and efficiently move things from north to south. It is going to be flabby, like if you're sitting around sort of doing nothing, right? So exercise is really important, and we don't have time to go into it today because today's about solutions, but there's a relationship between nitric oxide release and exercise, etc. If you want to learn more about it, check out my first book, Gut Bliss. The constipation chapter is like 20 pages long, and then there's another chapter called On the Move Towards Gut Bliss, which talks about the effect of exercise, what type of exercise, etc. So check out Gut Bliss for that. But let me just say again, in that first bucket, diet and lifestyle. So we have fiber, how much, what type, water, are you hydrating, and exercise, are you moving? Because as I'm fond of saying, if you're not moving, neither are your bowels, okay? And that's why we see so much constipation in nursing homes, for example, where people are sedentary. So that's first bucket. Second bucket, medicine cabinet. And again, I'm fond of saying we think of the medicine cabinet as a place to go to find solutions, and it often is, but it also often is the cause of the problem. So what are the things in the medicine cabinet that could be slowing you down? Antidepressants, painkillers, vitamins containing iron, blood pressure medications. It's a long, long list. So I can't go over everything here, but what I want to tell you, and over-the-counter drugs too, antihistamines. I had my own bout of constipation this summer when I was in Turkey and I was taking antihistamines for a long story of a reaction to insect bites. It has gone on and on and on. I won't bore you with the details or do any show and tell, but I was having pruritus, severe itching and hives, urticaria. and was taking antihistamines around the clock. I don't take any medication, period, ever, if I can help it, and certainly nothing on a regular basis. And the antihistamines were helping to control the reaction, but I found myself really constipated. In addition to the time zone travel, it was really hard to get a lot of fresh vegetables in Turkey where we were. So medications like antihistamines that are very drying. And for those of you who may be taking antihistamines, daily during allergy season, that's something to think about. Okay, so I just sort of a broad overview of the medications, but there are a lot more. So whenever you're taking something, whether it is a supplement, vitamin, mineral, or supplement, whether it is an over-the-counter or whether it is a prescription drug, I want you to look it up and see. And if they're listing constipation, within one of the sort of top 15 or 20 side effects, I want you to really consider whether that could be contributing, especially if this is something you're taking on a regular basis. Cough and cold medications, those are often really drying. They often have antihistamines in them. And again, anything for pain that can slow down motility. There is a whole new disease. Medical industry, pharmaceutical industry are really good at inventing new diseases. There is a whole new disease called opioid-induced constipation for people who are taking opioid medications. And of course, there are many people out there taking opioid medications who really need them, who are in severe chronic pain. But we also know there are many people out there who are addicted to these drugs and don't necessarily need them. And the portal for addiction is often through us, through physicians who are prescribing them, well-meaning physicians often who are prescribing them for pain. But OIC, opioid-induced constipation, is a real disease now. Of course, it's a drug-induced disease. And what do we use to treat it? More drugs, more drugs. Does that make any sense? That something is caused by a drug, that we're treating a side effect of a drug with other drugs that themselves have side effects. I mean, you can see where this is leading, right? Like, it's polypharmacy highway. So, of course, if you have opioid-induced constipation, the number one thing you should be doing is trying to figure out how to get off the opioid or how to swap it with one that is, going to produce less side effects on your GI tract, right? Not looking for more pharmaceuticals to add into that mix. So enough said about that. So medicine cabinet is a big one. And remember, it can be vitamin mineral supplement, it can be over the counter, and it can be prescription. And remember, when I talk about this, I'm not saying that drugs are bad or that you shouldn't be on it. I'm just saying that you have to recognize that none of this stuff is free. Prenatal vitamins cause constipation because of the iron in them, many of them, right? So you have to always, always, always do that, cost benefit analysis and decide whether this drug that you're taking is really worth it for whatever you're trying to treat, and look at that in the context of the other things that it's possibly doing to your body. Okay, the third, anatomy, physiology, and hormones. That's a big one. Anatomy, the voluptuous venous colon. Why do women have more constipation and bloating? Because we have longer colons, we have a wider pelvis, so the colon falls deep down into the pelvis, and there's less room in there because it has to compete for space with the ovaries, the fallopian tubes, the uterus, etc. We also have lower testosterone levels, which means our Spanx, our abdominal wall, is not as rigid. Our Spanx is a little stretched out. And I always like to say, even if you're Jillian Michaels with an 8-pack, you still have lower testosterone levels. And now I'm friends with Jillian Michaels. I've been doing a podcast series with her. We're sort of, virtual friends. But I'm going to Miami next week and we're having lunch. I had to brag because I'm so excited about my little lunch date with her. She's so awesome. So again, even if you're Jillian Michaels with the 8-pack, you still have lower testosterone levels than men. And so we have to work harder to create that rigid abdominal wall to keep the bowels in and bound so that they're not looping and we're not bloated and constipated, okay? So that sort of anatomy, physiology, the hormones, so things like hypothyroidism, fluctuating estrogen and progesterone levels around menopause, perimenopause, it's real. And what else? From a hormonal point of view, there was something else I wanted to tell you. Dysbiosis from a sort of physiological point of view. So when you have a disrupted microbiome, say you've been on tons of antibiotics, you're taking acid blockers, you don't eat a great diet, and you have a not so healthy microbiome, you can get overgrowth of certain species, undergrowth of others. And for example, the ratio of gases that are being produced when your bacteria ferment food can be off. So we see people who have methane predominant dysbiosis. I don't like to say SIBO, small intestinal bacterial overgrowth, because that makes it sound like it's just too much bacteria, where often the problem is not enough of the healthy species. But you can get more production of methane than is normal or recommended in your digestive tract, and that is strongly correlated with constipation. And the solution is not just to take a probiotic. Unfortunately, that's not how it works. You really have to change your diet so that you can really get true colonization, regrowth of some of these healthier species, okay? I just have to tell you, spoiler alert, all roads lead back to more plant fiber, more water, more movement, all right? That is, at the end of the day, that is a foundation on which better gastrointestinal health is built. Now, of course, are there other things? Are there supplements and so on and some medications? Yes, and believe it or not, I am actually going to tell you about some supplements and medications that are, Gut Bliss approved, right? Shocking, I know. I'm not gonna tell you like, yeah, go run 10 miles, drink a gallon of green smoothie, meditate, you'll be fine. I'm actually gonna give you some practical advice in addition to that can help with your constipation. So once you figured out what bucket you're in, and there's some more buckets too. Again, if you want the whole 20 pages, definitely check out Gut Bliss. But, I have there's shy bowel paracapresis where you're holding, there's anismus, there's pelvic floor problems, there's lots more to the anatomy than just the longer colon. There is endometriosis, there are fibroids. So when I said, there is always a cause, but you can't always treat it. Sometimes people have a retroverted uterus where the uterus is tipped and it's pressing on the colon, or you have large fibroids and you're not a candidate for having them surgically removed, or you have endometriosis that's also, difficult to get under control. So there are anatomical things that can press on your colon. There's a configuration of your colon. If you have a voluptuous venous colon, women on average, we have slightly longer colons. Why? So that we can absorb more fluid from the intestinal tract into the bloodstream to support the amniotic fluid during childbirth. Same reason we have a wider pelvis. And those things can lead to a lot more twists and turns in the colon. I'll tell you, I've done about 16,000 colonoscopies, most of them in women, not all. And doing colonoscopy in women makes you really good at doing colonoscopy, because the colonoscopy in a woman is much harder, sometimes twice as long, because of those reasons. Women, we have a longer colon with more twists and turns, more redundancy, as my male colleagues call it, tortuous or redundant colon. I call it a voluptuous venous colon, because who wants to be told their colon is tortuous? But really, it's lots of twists and turns, and it wraps around the uterus, the tubes, etc. So it is much more challenging doing a colonoscopy in a woman in general, much harder to get to the end. And similarly, it's harder for the stuff inside your colon to get out if you're a woman. That's why, again, we tend to be more bloated and constipated. Remember that abdominal wall, lower testosterone levels, not as rigid, even the Jillian Michaels 8-pack. Hi, Jill. So it is, we're going to have a lot more looping and more difficult for me to get all the way to the end, more difficult for the stool to come all the way out, okay? So what do we do about it? So once I have seen the patient and I have, talked to them, I've looked at their previous colonoscopy if they've had one, I've maybe done a colonoscopy if there's an appropriate indication, if they're of age for screening, 45 or older, or 10 years before the youngest relative was diagnosed with a significant polyp or colon cancer. So depending on what their personal and family history of colon polyps and colon cancer is, the screening may be at 45, it could be sooner. It's not that I would do a colonoscopy in everybody walking to my office, not by any stretch of the imagination, but if they have an indication, or let's say I'm reviewing their colonoscopy, I might find diverticulosis, which hadn't been emphasized to them by their previous gastroenterologist. And diverticulosis, I've done office hours on this before, and I have lots of resources on the website. Potholes in the colon, common cause of constipation, but that is a separate cause. A lot of the treatment is similar, still prescribed fiber, water, movement, etc. But that's sort of a different condition I'm not going to talk about today. But so I'm looking for what is the cause of this person's constipation. And I might check their thyroid function to see, do they have undiagnosed hypothyroidism and underactive thyroid? I'm looking at what their sort of menstrual history, menopausal status is. Even if they're not menopausal, are they perimenopausal? Those 10 years or so before you stop getting your period, where there can be a lot of hormonal fluctuations. I'm looking very carefully at their diet. I'll tell you, I'm getting ready to reopen my practice to new patients in a few weeks. I am so excited. And it's sort of, Digestive Center for Wellness reimagined. So one of the things I've been working on is an intake form. And thanks to the help of a lovely registered dietitian who's going to be working with me, Olivia Ashton Nutrition, I'm using a new patient portal called Practice Better, and you can customize all the forms. So the intake form is, I'm having so much fun with it, but I'm asking all these things like how many servings of fruits do you eat? How many servings of vegetables? How many different plants a week? How much water? All the things that I want to know that inform me what's going on in your gut. I'm putting those all in the patient intake form. So for those of you coming to see me, prepare to be tortured. No, it's not torture, really. It's so important. So I'm diving deep into the diet and the lifestyle, what kind of exercise, how often, etc. All of these things. I'm asking about medications, vitamins, mineral supplements, over-the-counter prescription, and I'm trying to get a sense of what's going on hormonally, anatomically, physiologically. Okay, so I've done all of that, and doesn't seem like there are any large red flags. I don't think this is a big fibroid uterus pressing on the colon or undiagnosed hypothyroidism. So what's my approach? Okay. I always want to start at the bottom of the pyramid. The bottom of the pyramid is a foundation of diet and lifestyle. And I have to bore you all with that again, okay? Because there is no point prescribing a medication with side effects for something that you can treat by, drinking a couple extra glasses of water. That's bad medicine. That's bad medicine. So we talked about that first bucket, diet and lifestyle. So I like my patients to follow the 1-2-3 rule: 1 veggie at breakfast, 2 at lunch, 3 at dinner. Challenge them by saying those should be 6 different vegetables. And I do vegetables because fruits are easier, right? People usually don't have a problem grabbing an orange or eating some berries, but people just seem to have an aversion to vegetables. I flip it. I do my green smoothie in the morning, and we have to do a whole separate office hours on the green smoothie because I literally think can cure most things going on in the gut. So I do a lot of my greens early with a green smoothie, but for those of you who are not so inclined, 1, 2, 3, 1 vegetable at breakfast, 2 at lunch, 3 at dinner. By the end of the day, you have 6 servings of vegetables. Why is that important? Because we're talking about increasing fiber in the diet, because a variety of different plants is one of, if not the most important predictor of microbial diversity, microbial health. So really important to keep track of that. Can make a huge, huge difference increasing the fiber. Water, simple. Minimum of half your body weight in ounces of water. If you weigh 150 pounds, that's 75 ounces of water. If you weigh 120 pounds, 60 ounces of water, etc. Now that is the minimum. And with that water, I'm not talking about coffee. You can get credit for tea if it's herbal tea. I'm not talking about, any kind of sports drink, just plain old water. You can do sparkling if the bubbles don't bother you, right? So minimum half your body weight in ounces of water. That is foundational. Here's the thing, it's plumbing. Gastroenterology, the digestive tract, is plumbing. And if your pipes were clogged, you would want to put thin liquids through it, right? That's how you unclog a pipe. You pour thin liquids through. Same thing. You are not going to be able to move those products of digestion from north to south, from in the gut to out the butt, if you are not hydrated. It is just it's mechanics. It just can't be done. If it's all dry in there, everything is going to clump together and it's not going to move. So I tell you, I could probably solve constipation in 30% of the people I see just by getting them to drink more water. This right here is my iron flask. I love it. It's all bent up from banging it around in yoga. This is 40 ounces. I try for 2 of these a day on the days where I'm going to my heated vinyasa yoga class at Down Dog Yoga, which I love. I try and do 3 of these a day, but minimum 2, minimum 80. And that is more than half my body weight in ounces, but I just like to get a little extra in the tank. I notice a huge difference, and not just in the bathroom, but a huge difference just with energy levels. My joints don't feel as achy. I feel clearer. While we're talking about the bathroom, I just want to overshare with you for a minute this whole kind of stool nirvana thing. So I ate a really good diet, lots of whole grains, vegetables, fruit, all of that. I ate a little too much chocolate, but I get in the stuff I'm supposed to get in. But the other day, I have to tell you about the other day. The other day, I had such an incredible stool nirvana day. Now, you know about the clean wipe, right? I like to talk about that, where you wipe and there's the toilet paper, there's virtually nothing on it because you've had a complete evacuation. It's all come out. Versus a schmeary wipe, where you're wiping and wiping and wiping and the toilet paper is still brown on it. Why? Because there's still stool up in the vault. But the green wipe is up there with the clean wipe. What's the green wipe? It's when you have so much plant fiber, particularly green vegetables, that the toilet paper comes out with a little green sheen. Like, it looks almost like grass, like if you were to wipe the toilet paper in grass. So let me tell you what happened with me. So I woke up and I had a big green smoothie, but I put some berries in it. I don't usually put berries in it. I usually put stone fruit like nectarines or maybe a little pineapple or mango, but it was coconut water, celery, spinach, and collards. And then I put some wild frozen blueberries in it, lemon, parsley, and celery. So for greens, serious greens, we had celery, collards, spinach, and then, you get some credit for the parsley too, but that's not a lot. So I had that big thing. I drink about 36 ounces of that. So I had that. And then I went to Bluestone Lane with my daughter, wanted to do some homework there. This is a while ago. She was studying for exams or something. So we went there and I had the green goddess salad, which is, all this green stuff with the avocado dressing. I had a big green goddess salad. And then I came home and I had some lentils and brown rice and salad. Let me tell you, I took pictures of this. I'm not going to show you because we don't know each other that well. But if you're my good friend, I'll show you. This stool came out of me and I was like, are you kidding me? It was green, like that brown green. It was like dinosaur stool almost. It had like a funny shape, but it had like this green tinge to it. And then when I wiped, it was green. It was like grass. And again, like, I'm a good eater, but you just heard what went into that, right? The big green smoothie, the green goddess salad, the lentils, the brown rice, the salad, and it was fantastic, let me tell you. So that is really the goal, right? That's like the gold medal. That is like you're up on the podium with your stool, so excited. It doesn't happen every day, but it's possible. It's possible. So I don't even know how I went on this tangent about my green wipe, but that is when there are a couple people on this call, plant-based addict and others, who I know you know what I'm talking about, right? That when you just really get so much good plant fiber into you, and the next morning you're really reaping the benefits. So let me get back to the solutions, what I gathered you all to talk about. Okay. So the first thing is, foundationally, you got to address the diet and lifestyle. So fiber, we talked about that in gory detail, water, half your body weight in ounces, and movement, right? You got to move. And many of us during the pandemic, are exercising every day. We're going to CrossFit and yoga and we're running. But the other, 23 hours of the day, we're either lying in bed or we're sitting a lot. So for many of us, what has decreased is ADLs, activities of daily living. I know when I was in my office, I was back and forth with patients in the hospital and, moving a lot more than I have been in the last year, even though I'm still sort of working out the same. So that really makes us a lot less active. And so a lot of us have seen more sluggishness in our bowels as a result of that. So, movement, just like you're not going to build strong muscles sitting on a couch, you're not going to build a strong digestive muscle with that ability to push that stool out efficiently if you are sitting on the couch. So get moving. So that's sort of bucket number one. My regimen that I start with for most patients is a fiber supplement in the morning and an osmotic cathartic at night. So let's start with the fiber supplement. Two favorites are psyllium husk and acacia fiber. These are both primarily soluble fiber. But the difference between the psyllium and the acacia, and it's a big difference, is psyllium, and that's P-S-Y-L-L-I-U-M. So the big difference is that psyllium husk is primarily soluble. There's a little bit of insoluble fiber in there, but it's viscous. What does that mean? It means it forms a thick sort of gel-like substance, right? Acacia fiber is mostly soluble fiber, dissolves fully. It is non-viscous, so it is very palatable, easily dissolves, it's odorless, tasteless, grit-free would be the way I describe it. So psyllium, in my experience as a gastroenterologist, is a more efficient broom for sweeping out the colon, but acacia is more tolerable. And I have a lot of patients, so I usually will start people on psyllium, and if they're like, ugh, it's just too much, it's too thick, sort of gelatinous, it's just not agreeing with me, I'll switch them to acacia. Or for a lot of my patients, I'll do a combination. I'll say, okay, I want you to do a full tablespoon of psyllium husk in the morning, but if all you can get in is a teaspoon, that's fine. And then I want you to do acacia during the day. Now, I always want you to do the fiber early. Why? When I say early, before noon, because our GI tract is most active early in the day. The peristalsis is tied to the circadian rhythm. So once the sun sets and the day, slows down, there's not a lot of movement. And I have this discussion with my husband weekly. I'm like, we've been married 20 years and you're still asking me, can you take your fiber at night? No, you got to take it in the morning, which he does usually, but he still always asks me if he misses it. So you want to have that fiber early. It doesn't have to be, crack of day, 5 a.m., but ideally somewhere north of lunchtime so that you have plenty of time for that fiber to get through. Remember, it's got to go through the stomach, the duodenum, the jejunum, the ileum, the cecum, the ascending colon, the transverse colon, the descending colon, the sigmoid colon, the rectum. That's, 20 to 30 feet. And so you want that to happen, A, when you're upright, because gravity is going to help move it down, and B, during the day when the GI tract is more active. So that's a fiber. The other important thing about the fiber is you have to take it with a lot of water. Otherwise, it's just going to sit there like a big fibrous gelatinous lump in your upper GI tract. It's not going to get down to the colon where you need it. So the way I have my patients do it, I'll often start them on a teaspoon before each meal to sort of get used to it, or at least before breakfast and lunch, and then consolidate into one heaping tablespoon, the big spoon. And I have them mix it in an 8 to 12 ounce glass of water, mix it well. I don't generally recommend the flavored Metamucil, certainly nothing with artificial sweeteners. Absolutely not, terrible for your gut and will give you gas. So regular sugar is fine. Or if you want to be hardcore and just do the unflavored psyllium husk, in that case, I like the Yerba Prima brand, YERBA PRIMA, no relationship to them. But it's just a good sort of pure psyllium husk. I'll warn you, it tastes like, cut up cardboard. It is not delicious. So you can add a little splash of something, little splash of lemonade, little splash of orange juice, not a lot. You don't want it to get thick. You don't want to turn it into fruit juice, gelée. But you can add a little splash of something. And here's the thing. So an 8 to 12 ounce glass of water, you want to mix it up really well and you want to drink it briskly. Literally chug it. This is not something to sip on like a cocktail, because then it's going to get silty. That viscous gel is going to form in the glass and you're not going to want to drink it. Okay, so mix up, drink briskly. Really important. Drink a second glass of water after. That's your chaser, because you're trying to wash it down into the colon. Okay, use the same glass. Let me get a little swig. Use the same glass of water. You'll see there are dregs of the fiber at the bottom. So just fill the same glass with water, capture all that fiber, drink it again. So ideally you're drinking it with 16 to 24 ounces of water, right? Because with the initial 8 to 12 ounces of water you mixed it with, and then a second 8 to 12 ounce chaser somewhere before noon. That is key. So I'll do either psyllium husk or acacia. Start with the psyllium, but if you really can't abide the psyllium and you're just like, this is terrible, then switch to acacia. And for acacia, I like Heather's Tummy Tamers brand, and they have little stick packets too. But any sort of, just good unadulterated acacia fiber. So where does this stuff come from? Psyllium husk. Most of the psyllium we get is sourced in India, and it's from a shrub-like herb called Plantago ovato. And the Plantago ovato, each plant produces thousands of little seeds, gel-covered seeds, and that's where we get the psyllium from. So it is just the seeds from the Plantago ovato shrub-like herb. Acacia fiber, which is sometimes called acacia gum, is sap. And so it's not seeds, it's sap from the acacia tree, ACACIA. It's one of my favorite words in spelling bee. If anybody else does a New York Times spelling bee, or more accurately is obsessed with the New York Times spelling bee, whenever there's a C, and an I, I'm like acacia, acai, and acacia. And onion is another favorite one of mine, because all you need is an O, an N, and an I. So acacia is made from the sap of the acacia tree. It's a gum tree, grows in different parts of Africa, Senegal, etc. And that is how we get that. And that is also used, I mean, you know, gums sort of have a bad rap these days, right? Because gums we associate with emulsifiers, etc. And that's true for some of these more processed gums, but I don't include acacia in a lot of that category because it's been found to have some pretty significant benefits in the GI tract. But of course, you want to get it as a fibrous product, not it's powdered and turned into a fiber, not as, you know, filler in ultra processed food. So that's acacia fiber. So some sort of fiber in the morning with a lot of water. And then at night, what do I use? Particularly in the first few weeks of the fiber. If somebody is really constipated, if I just give them a lot of fiber, here's what can happen. I can just kind of gum up their GI tract. So now they feel bloated and uncomfortable with a bigger bloat plug because now they have a big fibrous mass sitting in their GI tract. So I will often, depending on a lot of things, like what's their hydration status, how much are they moving, how active are they, etc., I will often give them a little bit of an osmotic cathartic at night. So what is an osmotic cathartic? It's something that's going to draw water from the bowel, usually from the small intestine, into the stool to make the stool more soft, more liquid, and easier to pass. My favorite osmotic cathartic would be something like a magnesium supplement, which is, you know, some people call it sort of in the category of saline laxative because it can pull water in. I avoid anything with senna for long term. Why? Because senna and those stimulant laxatives are very habit forming. Now, osmotic cathartic saline laxatives can be habit forming too, but the stimulant laxatives like senna are bad for your colon. You can become very dependent on them, and there's some studies that link them to colon cancer. So that might be fine, like as part of a bowel prep or something for a colonoscopy, but that should not be something that you are relying on every day. Do they work? Yes, fabulously, but they're not good for your gut. The magnesium I find is quite safe. I use magnesium oxide primarily. I might start somebody on, 400 to 800 milligrams of magnesium oxide. But my go-to product, if somebody really needs a lot of help, is something called Oxy powder. And again, I have zero relationship with any of these companies. They don't even know. I mean, when I get it to play around with, I buy it off the website. I don't get samples from them. No relationship. Let me just be clear. So Oxy powder, get it on Amazon. I've actually never seen it in the store. Is a form of oxidized magnesium oxide. The serving size is about 4 capsules, but most people don't need a full 4 capsules. I usually start my patients with anywhere from 1 to 4, just depending on what's going on and how much they need. I'm just looking, seeing my husband is pulling in to make sure when I'm talking about all his bowel stuff, I do it when he's not here. So if you run into him, don't tell him that I've been talking about his fiber mixing habits and him asking me every week if he can take the fiber at night. So just keep that between us. Okay. So the magnesium oxide, the Oxy powder, the 4 capsules is 1,400 milligrams, which means that each capsule is 350 milligrams. You see how good I am at math. Most people don't need 4 capsules. And in fact, I usually have them do this in the evening, before dinner, after dinner. The 4 capsules is likely going to give you some cramping because as that fluid gets pulled into the small intestine, all that water, there is some cramping that can go with that, and it can be dehydrating. So dehydration is one of the main concerns when you're taking this stuff. So you should be taking this ideally with at least 30 ounces of water. Okay, which means you probably don't want to take this right before you go to bed. You don't want to drink 30 ounces of water right before you go to bed. You'll be up all night peeing. So get that water in earlier. Maybe if you know you're going to take some sort of magnesium oxide, get in a lot of water at lunchtime, early in the afternoon, so that when you take your whether it's mag oxide, a few, in 200 milligram capsules and you're taking 3 or 4 a day, or you're doing the, super duper strong oxy powder, you are well hydrated. That's really important so that you don't wake up the next morning feeling really dehydrated. And if you've never used the oxy powder, maybe just start with 1 or 2 capsules. I would be wary about doing 4 capsules of the oxy powder. I have some patients who get really, really backed up, and I have them on a regimen where usually once a quarter, sort of seasonally, they're doing a liquid diet over a weekend, and they're doing a bottle of citrate of magnesium. But a lot of these are patients of mine who've had a lot of abdominal surgery. They have a lot of abdominal scarring, adhesions, and they know when they're getting backed up like that. And for a lot of them, I've helped to keep them out of the hospital. These are people who are being admitted with bowel obstructions. And I tell them, look, when you start to see things slowing down and you realize you're constipated and you haven't been having a lot of bowel movements, go ahead and do the clear liquid diet for 24 hours or 48 hours and get in a bottle of magnesium citrate, every afternoon for 1 or 2 days. This is sort of like a modified bowel prep to empty everything out to keep them from getting a bowel obstruction. So this isn't like a recommendation for the average person, okay? This is somebody who's under my care, who's at risk for a bowel obstruction. But a sort of lighter version of that, if you are somebody who, let's say every time you go, you feel like you're leaving 10 to 20% of the stool behind. First thing to do is to try and figure out how not to do that. But let's say this is happening. So that means every 5 or 10 days, you're going to be really backed up. Doing a day of, I don't recommend colonics for reasons that we'll have to go into in another office hours, but doing a liquid diet. So that could be, you're doing a little bit of juicing, you're doing a smoothie, but a thinner smoothie, not a thick smoothie with all that fiber. You're doing some soups or broths. So whether you're doing a sort of clear liquid diet or just a liquid diet, to give things a chance to move through. And maybe you're doing some oxy powder in the evening. If you're really trying to lighten things up, I wouldn't recommend going ahead and doing the fiber in the morning. I would just take the fiber out for a couple of days and do some magnesium. That can work too. Occasionally I will recommend Miralax, but not for the long term. So if I'm starting somebody on fiber in the morning, I'll usually start them on magnesium, but sometimes I start them on Miralax. And then once things are going well, after a week, 10 days, 2 weeks, I'll tell them, okay, stop the Miralax and only use the Miralax as needed, because Miralax is a first cousin of antifreeze. And it's just not something that you should be ingesting every single day. So that's my approach, is typically foundationally diet and lifestyle, fiber, exercise, hydration, look in the medicine cabinet, think about the anatomy, the physiology, the hormones, and then fiber in the morning, either psyllium or acacia, and some sort of magnesium at night, occasionally Miralax at night, but not long term. All right. Let's talk about what I don't like for constipation. I don't like the drug Linzess. It's been out for about 10 years, linaclotide. Really interesting thing about Linzess, it was developed in a lab where it's an offshoot of an enterotoxin produced by a form of E. coli. That's not what the drug is today, but this is where the research came from. So there's a bacteria, E. coli, that was producing an enterotoxin. Entero means gut, and toxin, you know what that means. So it's something toxic to the gut that was responsible for traveler's diarrhea. So it was inducing an illness, traveler's diarrhea. And they said, oh, we can use this. We can kind of rejigger this to create a drug that can cause diarrhea. And so that's what they did. So again, I'm not saying Linzess is, a toxin produced by bacteria that causes traveler's diarrhea, but that's where the origin of the drug came from. And what's the main side effect? Well, it's diarrhea. So you can usually get around that by adjusting the dose. But here's the thing. There is a black box warning on this drug. And things have to be bad for the FDA to put a black box warning, because the FDA is very much a drug advocacy organization. A big role that they play is to advocate for the pharmaceutical industry. And then, they do some consumer advocacy too, but their goal is to get these drugs out to the public. So when they put a black box warning, that is really a sign you need to watch out. And the black box warning is about dehydration in young people. So certainly no child should ever be on this drug, but even teens, the black box warning goes up to 18, but nobody under 21 really. And I think maybe I've prescribed Linzess maybe once or twice in the last 10 years since it's been out, but the main problem I see is nausea. So it can cause dehydration, it can cause dizziness, it can cause low potassium, it can cause vomiting, it can cause GI bleeding, but nausea is a thing that I have the most problem with. And again, why would I use a prescription drug that is fraught with side effects if I can solve it by, getting you to drink more water or eat a little more fiber or whatever it is? Now, some people, you do all of those things and it doesn't work, right? But you always want to start with that, because this is not a simple drug that you just take and, presto, I'm having fantastic bowel movements, problem solved. Okay, the drug is problematic. So Linzess, and then Trulance is sort of similar mechanism of action that's been out a few years, similar side effect profiles. So I don't love these drugs. It's always on an individual basis. I am a conventionally trained doctor. I have a white coat, a prescription pad. I try to use it as infrequently as possible, but I'm not averse to writing a prescription for a pharmaceutical agent if I think that person really needs it. So it's all about judicious use. I mean, we all benefit from having a wide array of pharmaceuticals at our disposal, but we want to be judicious in how we use them, and we want to be realistic about what this drug is going to accomplish and the side effects, right? You don't want to swap constipation for unrelenting nausea. That's not a good trade-off. All right, I am going to stop talking and take some questions. Okay, how do you know if you have acid reflux? Okay, this is a great question, but this is not a great question for constipation. So I promise you, check out, I've done office hours on acid reflux before. Check out one of those, and we'll follow up there. Okay, so let me scroll back and see. What about iodine supplements? Somebody wants to know. What's good by Sharon? Yeah, iodine supplements are not on my radar at all for constipation. Okay. Citrate or oxide, Hampton Girl 85. So magnesium citrate in the liquid form is my sort of emergency evacuation plan, if you will, for somebody who's really backed up. It acts quickly and dramatically. Often some people can see effects in as little as 30 minutes. So that would be like a bottle of liquid magnesium citrate. Magnesium oxide tablets, I usually have somebody do the evening before, and that is, sort of gentler, but it depends on the dose. So if you take a big whopping dose of magnesium oxide, you're going to see a more dramatic result. But generally I use the citrate for the liquid emergency evacuation, really need to get it out, and oxide for the more regular every day. Okay, Tweet and Ginny wants to know, can you take the oxy powder in addition to magnesium glycinate that I take at night? Ginny, I wouldn't use both. I would use either or. So if you're using them, and again, I just want to say for everybody, I know you know this, I am not your doctor. I wish I were, but I am not. This is for educational purposes only. This is not medical advice. This is just hypothetical educational discussion for what I would do for patients in my practice, all right? If somebody came to me in my practice who was taking oxy powder and magnesium glycinate, I would say choose one. Go with the magnesium glycinate, typically gentler, max it out, add some fiber in the morning, see how you do. If that's not working for you, then try the oxy powder. I wouldn't do both together. It can be a little bit unpredictable. I am fine with doing psyllium husk and acacia fiber together, but with the magnesium can get a little tricky. Okay, what else do we have? Anita says she takes magnesium citrate. Good, fantastic. I hope it's working out well for you, Anita. And okay, so the question is, safe for a 12-year-old severely constipated person, also safe for tree nut sesame, egg allergy. I'm not sure what you're asking is safe, but if you're asking is psyllium husk safe for those allergies, if it's pure psyllium husk, it should be, but check with your child's allergist. And same thing, it depends on the magnesium preparation. So you should look for those allergens. Unfortunately, those are allergens that should all be listed. Should say whether, made in a facility with tree nut, sesame, egg allergy, but should be fine. Some of these different supplements have fillers in them, so you have to be careful with that. But I always recommend something that just says, pure psyllium husk, ground husk. The 12-year-old who's severely constipated too, you really want to look at a couple things. The dietary habits, are they getting enough fiber? And if they're not, could you make a smoothie for them with some fruit or something like that? Are they hydrated? Are they holding the stool? Are they not going to the bathroom at school? Because, who wants to go to the bathroom at school when you're 12? And so are they holding their stool in and then can't get it out when they want it to come out? So I'm always really concerned about medicating children, even with a supplement. I really want you to, think about some of the things I've talked about and see if there's something you can do there. Even if you can just get that 12-year-old to chew on a carrot. Smoothies are a great way to get some fiber into them. And for a 12-year-old, if your 12-year-old is a picky eater, I would recommend a smoothie with a lot more fruit in it, and throw some spinach in, some greens, but do strawberries and things like that, berries, and make it taste good. Okay. Is it okay to take psyllium husk first thing in the morning? Yes, it's absolutely fine, but lots of water. And make sure you're awake. Don't be lying in bed flat drinking your psyllium husk because you might choke on it. All right. Somebody says, like colonoscopy prep solution. Yes. What about psyllium capsules? Anita, that's such a great question. Psyllium capsules are okay if you absolutely cannot tolerate the actual powder. But what I have found is that the capsules don't dissolve well and they tend to gum up in your gut. So in my experience, even for the same gram, like if you're taking a 500 milligram psyllium husk capsule, and you're taking, let's say 8 of those, so that's 4 grams, versus you're taking 4 grams of the powder, I find the powder is a lot more effective in patients. But I do have patients who take the capsules. It's just more convenient, especially if they're traveling, they can't tolerate the powder as much. So the capsules are okay if you need to take them. What else we got? With or without food. Bob, I'm sorry, I'm scrolling backwards, which makes no sense. So I'm not sure if you're asking me with or without food, but if you're asking me about the psyllium, doesn't matter. It's pretty filling. So, if you're taking this after a big, 3-egg omelet or a huge bowl of oatmeal, you might be a little full, but you can take it with or without food. And the magnesium, same. You can take it before or after eating. All right. What else do we have? I apologize for going backwards with the questions. Okay, here's a good one. You mentioned the uterus can be pressed up against the colon. Is it also possible it can be pressed up against the bladder, causing bladder incontinence in a young female mid-20s? Absolutely, absolutely. And something to think about also is endometriosis causing that. So if you or somebody is a young female in their mid-20s having bladder incontinence, you definitely want to get that checked out. Who I would recommend is a urogynecologist. So that's somebody who specializes in both urology and gynecology, okay? A urogynecologist. And anti-diet IBS dietitian says you can also get hydration from foods you consume, like fruits and vegetables. Yes, absolutely, tons of hydration. Anybody ever juiced a cucumber? You see how much liquid there is in that, or celery, or an orange. It's a great way to get hydration is from fruits and vegetables, for sure. Speaking of colonoscopies, a gut coach wants to know, what impact does benign polyp removal have on the gut lining and long-term biome health? Realize it's a tangential. So it's such a good question. The actual removal of the polyp has minimal effect, but the bowel prep for the colonoscopy has significant effect. What the studies have shown, and there have not been a lot of them, is that it disrupts the microbiome, the bowel prep, and of course this depends on what prep you're doing, right? Some are more disruptive than others, but all of them disrupt the microbiome, but it tends to revert back to very close to baseline, if not baseline, in about 2 to 3 weeks. So you're not doing long-lasting damage to things. What I find is a lot of my patients with inflammatory bowel disease, with Crohn's and ulcerative colitis, they find the bowel prep can sometimes precipitate a flare-up of their symptoms. And it's probably as a result of that microbial disruption. But removing the polyp, the way we do that, it's very cool. We have something called a snare, which is a metal structure. So it goes in, it has a handle on the end. We put it through the colonoscopy, through the colonoscope, collapse. So it's just like a thin, straight, like a hairpin. And then when it comes out the end of the scope, we have a handle where we can open it. So then it becomes a loop like this, like almost looks like something, like the needle threader. And then the polyp is sticking up in the colon like that. So we plop it over it and we tighten it. and then we have it hooked up to current, and we run an electric current through it, and it basically cauterizes, uses electric current to cut through that tissue. It's a very cool procedure. It, is generally very safe, but if the polyp is very flat and very close to the lining, if a polyp is sticking up like a lollipop on a stalk, it's easy to put it over it and cut it off. But if it's very flat, you have to be very careful how you kind of scrape it off, so the flatter the polyp, the more challenging it is to remove it. But generally, a very safe procedure. And the amazing thing about polypectomy is that prevents colon cancer. Cancer grows from polyps. And so if you remove the polyp, you remove the potential for this to ever turn into colon cancer. How great is that, right? Okay. Anti-diet IBS dietitian says, a microbiome loves diversity of plant-based foods. Absolutely. I cannot mention it enough. The American Gut Project study from 2018, 30 or more different plant foods per week was associated with a much more diverse, rich, healthy microbiome compared to 10 or fewer. And it didn't matter what you call yourself, right? You could be an omnivore eating 30 different plant foods per week versus a vegan eating less than 10. My daughter right now is in a green bean kick, and she literally wants to eat green beans every day. Sometimes she takes them to school and has them after crew workout, and she has them for dinner every night. Every time I'm going to the grocery store, she's like, do we have green beans? Make sure we have green beans. And I love the fact that she's eating tons of green beans. She likes the French beans. But I also am like, okay, it's time to could we eat some Brussels sprouts and some cabbage too? She's really sort of fixated. And I think kids go through that. She went through a phase, she was obsessed with nectarines, and it was 3 or 4 nectarines a day. Now it's oranges. Last night she was like, should I have orange number 4? I was like, go for it. So let me be clear, I'm not complaining. I think it's great that she, is choosing to eat these healthy foods, but I want to remind all of us we need a wide array, right? Okay, so anti-diet IBS dietitian, thank you for reminding us of that. Okay, what is the impact of hypothyroid and Hashimoto's on the digestion? So Hashimoto's is an autoimmune thyroid condition where the thyroid has been damaged, or usually antibodies to it. It is often transient, so we can see it, around pregnancy, postpartum. And I want to remind you that if your thyroid is damaged, it doesn't necessarily mean it's damaged for life. So make sure and have that conversation with your endocrinologist. With Hashimoto's, we can see an overactive thyroid, what we call thyrotoxicosis or hyperthyroidism, or we can see an underactive thyroid, hypothyroidism, or we can see euthyroid, meaning your thyroid function is actually normal, even though you have Hashimoto's. So Hashimoto's is a damage to the thyroid, but it can be associated with overactive, underactive, or normally functioning thyroid. Hypothyroid means your thyroid gland is underfunctioning. First thing I want to tell you is make sure you had an actual legitimate thyroid test for this, because there are a lot of tests out there that claim to, be super sensitive, and they are telling people with normal thyroid function that they have an underactive thyroid function, and then they're selling them a thyroid supplement. And that, if you really don't need a thyroid supplement, those supplements are going to make you produce more thyroid hormone. And if your thyroid hormones are actually okay, but this super sensitive test is telling you they're not okay, you could throw off your thyroid balance, a homeostasis. So make sure, I always want people to see an endocrinologist and make sure that this is a legitimate test, because there are a lot of illegitimate ones out there floating around whose main purpose is to sell your supplement on the back end. But the impact, which is the question you asked, is that it tends to slow things down in the GI tract. The thyroid is like air traffic control. And I will have to say, just to plug Gutless again, I have a whole section in there on, hormones and, what's going on there, and estrogen and thyroid, etc. And here's the thing, normally your thyroid gland, air traffic control, literally every second it's saying okay, she's going for a run, she needs more, okay, she's sleeping, okay, she's stressed, all right, she's about to eat. It's constantly taking a measure of what's going on in your body and deciding what do you need, and putting out just, the right amount for what you need. And when people have thyroid disease and the thyroid isn't functioning and they're taking a medication, it's usually on a once a day or twice a day dosing. It's very hard to sort of mimic what the body's normal thyroid function is doing. So I really empathize with people who, or if they've had their thyroid removed, because often when they're taking thyroid replacement therapy, and I'm, great that it exists, but they just feel they're like, this isn't like how my thyroid was behaving when it was in my body and functioning well. So I think the moral of that story is too, if you can get your thyroid to perform better, that's always, a better alternative to taking the medication. Now, if your thyroid isn't working, you have to take the medication, so be it. Here's the thing though, because of the way these feedback loops work, if you are taking an external thyroid supplement, it's suppressing your native thyroid gland. Now, if your thyroid gland isn't working, it doesn't matter because it's not making sufficient thyroid hormone. So that's a good thing. But let's say your thyroid hormone is working, but you've had one of these wacky tests that tell you it's not working, and you start taking thyroid hormone, it's going to suppress your native thyroid gland. And so you're relying on this artificial supplement that's not going to be as effective and efficient and well designed for you as your native thyroid function. So that's one of the concerns that I always have with some of these tests out there. Okay. All right. So these were such great questions. Hi, Alicia. And Lori wants to know, will I take out-of-state telehealth patients? I will, Lori. If you check the website next month, I apologize, it's taking a while. I'm doing some renovations to my office and redoing the website. We have a new patient portal, so I want to get everything just right for everyone. I will be doing second opinion consults for out-of-state patients. I really want to try and, include as many people who need help as possible. And I'm so excited to be back. Okay, we are right at the top of the hour. I know I started a little late today. What's Good by Sharon, plant fiber meaning lettuce. Yeah, lettuce is plant fiber. Now, lettuce is also a lot of water and chlorophyll, so, it's plant fiber. It's not dense plant fiber, particularly if it's iceberg lettuce, but it's all good. So the other types of fiber that are really good, denser, would be legumes. So that would be things like lentils and split peas and chickpeas. It would be that fibrous, dense fiber like asparagus, especially the stalk, broccoli, especially the stem, all of that. So, beans and greens are what I always want to encourage people to think about. And there's really great data in terms of the number of servings of beans that you have, adding not just life to your years, but years to your life, actually, in terms of life expectancies. Some interesting studies there, as well as, a more robust, diverse microbiome. But lettuce is good, yes. Not lettuce alone. Don't rely on only lettuce to do the job, okay? Eat an apple too, have some split peas, have some lentils. All right, let's see. Anita, do I have tips for people sitting in wheelchairs? That's such a great question. Yes, you can still be active even in a wheelchair, and doing twisting things are really good for digestion. So, upper body stuff will still get things going, and then twisting movement. So, not my area of specialty, but I'm sure you could find some resources online for a wheelchair workout, and anything that's giving you, lateral rotation, stimulating the gut. So thank you for asking that, and for, making us think more broadly, not just people who can go out and run 10 miles, but people who may be confined to a wheelchair but still want to have healthy bowels too. So thank you so much for that, Anita. Sharon wants to know, they say to take magnesium, but doesn't that ruin the muscles? So relying solely on magnesium without doing those other things can create some dependency, not as much dependency as a senna laxative, but yes. So, my goal with this stuff is I always want to get you going. And then I want to see, okay, like you're going, you're having, big, huge, giant stool every day, everything's good. Now, how can we slowly withdraw that and continue to have stool nirvana using diet and lifestyle, exercise, etc. So we don't want to rely on these things long-term if we don't have to. Okay, you know what? I think we're going to stop there because we're at 1:04, but it's always such a pleasure to join you guys on Tuesdays. I have to think about what we'll chat about next Tuesday. We haven't done irritable bowel syndrome and some of the basics in a while. So, message me, put some stuff in the comments, what you'd like to hear about. And check out the website, robynchutkan.com, ROBYNNECHUTKAN, or gutless.com for lots of resources. Go to the archived office hours on either website, and you can look through and see what we've done. And then these are all up on Instagram. I have to get them up on YouTube. And I'll see you next week. Okay.